Good day, everyone, and greetings from Vellore in India. The third edition of the WFH Guidelines for the Management of Hemophilia was published in August 2020 and has 340 practice recommendations arrived at through a well-defined, evidence-informed, consensus-based process. I'm Alok Srivastava from the Christian Medical College, Vellore in India, and these are my disclosures. It has been a great privilege to lead the development of all three editions of the WFH Guidelines for the Management of Hemophilia since 2005. They have all been designed to address practices all over the world. The second edition of the guidelines, which was published in 2012, has served the community well in publications with more than 1,200 citations and in clinical practice with more than 1.1 million downloads in 6 languages around the world. These numbers are a reflection of the foundation defining the crafting of these guidelines, that the principles of management of hemophilia are the same all over the world, with the major differences only being in the doses of the hemostasis products being used in resource abundant or resource restricted environment. For this third edition, like for the earlier ones, not only were multidisciplinary subject experts included as the core authors of different sections, but this time we also had patients or their families on these panels, along with the process experts, for the recommendations to be drafted after evidence tables were constructed with data extracted from systematic searches of the available literature carried out by professionals implementing a defined strategy. The recommendations were finalized through a Delphi process. Given the advances in the field since the last edition, 5 new sections were added, shown here in blue, emphasizing the significance attached to them in current understanding of care and its delivery for people with hemophilia. These include sections on principles of care, genetic diagnosis, prophylaxis, inhibitors, and outcome assessment. An entire section also exists to explain the methods used for creating these guidelines. This presentation will be focused on the section on principles of care. The concept being to define what care means and its scope, organization, and delivery. The first attempt at such a definition was from the EHAD more than 10 years ago in 2008. 5 years later, a survey conducted in 14 countries showed major variations in the application and the ability to comply with these principles in the real world. This showed that even in well-resourced Western European socioeconomic environment, a system of audit and surveillance may be needed to ensure that the principles of care are met or constantly strived for. Nearly 10 years later, a similar document was crafted from the Asia-Pacific group, which borrowed the broad concepts from the European document, but with significant modifications. As shown in this slide, apart from restructuring the European principles, there's much more emphasis on education and training of healthcare professionals, laboratory diagnosis, including genetic diagnosis, as well as the management of musculoskeletal complications, all very relevant within the context of a much wider socioeconomic, healthcare, and cultural diversity of the region, which accounts for 55 to 60% of the world's population. The section on principles of care in the WFH guidelines is a synthesis from these 2 predecessors, but with its own unique features. Overall, they may be considered under 2 categories: those related to organization of care, shown on the left in blue, and those related to the delivery of care on the right in black, all of which will be discussed in more detail during the rest of this presentation. The first principle refers to the recognition that care of people with hemophilia extends beyond hematologists and has required a multidisciplinary team working at hemophilia treatment centers which need to be networked to ensure that comprehensive care is provided. A national registry should capture the details of all people with hemophilia, ensuring correct diagnosis along with accurate documentation of the treatment and outcome. A robust system for procurement of adequate therapeutic products is also critical. All this should be adapted to the technological, socioeconomic, and cultural realities of the country in context. A common challenge for healthcare authorities and professionals at the beginning is to understand the context, meaning, and scope of a hemophilia treatment center, its structure and functions. To help with planning and establishment of such centers, the WFH has provided a template for the hub and spoke model, where the more advanced comprehensive care centers will work with the more basic hemophilia treatment centers to create a network that can seamlessly provide the required services for all people with hemophilia. The services, as mentioned in this table, are not set in stone, but should be adapted to local requirements. The next principle refers to the creation of carefully designed and transparent system with engagement of all stakeholders, including patient representatives, for procurement of therapeutic products which are critical to providing effective care, recognizing also that they could account for more than 90% of the total cost of care. The aim should be to get safe and effective products within the available budget to address different patient requirements. Again, there are WFH documents which can assist in this process. The challenges of maintaining continuous supply and distribution in a way that these products reach all people with hemophilia in the country is a critical issue. Most importantly, the planning process should take cognizance of the fact that quantities procured should be able to offer prophylaxis to all people with hemophilia ultimately, starting with young children, as episodic treatment does not prevent long-term complications of hemophilia. The third principle refers to the diagnostic services which are essential for correct identification of hemophilia. This section includes both hematological diagnosis based on clotting times and factor as well as inhibitor assays, difficult as they have been in establishing around the world, as well as the approach to genetic diagnosis using different technologies that are increasingly emerging to guide practice and clinical management of carriers and for prenatal diagnosis. This approach could have special relevance in countries with low detection rates. This busy slide has data from one of the recent WFH annual global surveys and shows the extent of underdetection of hemophilia around the world. While countries with good universal healthcare and hemophilia registries, such as the UK, France, and Canada, document 100% or more, with others ranging from 50 to 60%, in USA, Japan, Brazil, Australia, and Russia, about 15% in China and India, and other large population countries like Bangladesh, Ethiopia, Indonesia, Pakistan, and Nigeria at 5 to 10%. At this rate of detection, we may never be able to reach a high detection rate in these countries. What this slide shows are some global numbers and the increments achieved over 2 decades of attempts at diagnosis. You will notice that with nearly 3 decades or more of efforts towards enhancing diagnosis, we have added 15% to what existed before. The proportion would be even lower if we take the higher incidence and prevalence, which has recently been estimated, as shown on the right. This just goes to further highlight that the current paradigms for the diagnosis of bleeding disorders have been extremely difficult to establish widely in the world, and significant innovations are needed to address this major lacuna. The fourth principle refers to designating the multidisciplinary team and their training. Towards establishing the team, the composition reflects the need towards specific diagnostic and treatment requirements of people with hemophilia. Conventional medical training often does not provide adequate knowledge and experience to healthcare professionals in the management of hemophilia and other hereditary bleeding disorders. Additional orientation is therefore needed. The WFH has a range of extensive training programs along with several other international, regional, and national organizations. The next principle addresses the fact that the evidence base for much of the practices in hemophilia are not strong, and that specifically directed clinical research is needed to address these gaps. Some of the areas that would particularly benefit from further studies have been identified as optimal use of hemostasis products, both clotting factor concentrates and the alternative products, for prophylaxis as well as management of musculoskeletal complications, and relevant ways to assess long-term outcomes. There are many more. The next principle refers to one of the unique features of these guidelines from the very first edition, which has been to capture different practice patterns in the world. This is a large table with many numbers, but broadly divided into two sections: those using lower and others administering higher doses for the same hemostatic challenges. These are mostly a result of access to and cost of products rather than strong evidence either way. Practice data has shown that lower doses are also effective, but require closer observation for failure of hemostasis and may require supplementation in a few cases. Achieving effective hemostasis to prevent bleeding and related complications in all people with hemophilia should be the uniform objective of such interventions all over the world. The seventh principle acknowledges the need for a multidisciplinary team to effectively manage all problems that people with hemophilia have conventionally faced, with particular emphasis on the diagnostic and musculoskeletal specialists, apart from the hematology specialist. You will also notice that the nurse has been specially highlighted. This is to emphasize that the nurse is the one person in the team who is often full-time in hemophilia care and anchors the entire service. The two important issues included in this section are related to the transition of care from the pediatric to the adult teams and the special attention which needs to be given to patient empowerment with as much knowledge about this condition as is possible for them to absorb and engage with their healthcare professionals. The eighth principle recognizes the core importance of effective regular clotting factor concentrate replacement in a manner that would allow people with hemophilia to function as their non-hemophilic peers. Till about a decade ago, with the conventional standard half-life clotting factor concentrates, this was very difficult to achieve. But with the advent of the newer hemostasis products, including the extended half-life clotting factor concentrates and the factor VIII mimetic emicizumab, as well as more alternative hemostasis products which are in advanced clinical trials, this is becoming much more feasible. Access to such products and their optimal use is the most important aspect of hemophilia management. In fact, the most significant message from these guidelines is that the standard of care for all patients with severe hemophilia is regular replacement therapy or prophylaxis with clotting factor concentrates or other hemostasis products to prevent bleeding starting early in life. It has also become very clear that episodic management of bleeds does not alter the natural history of hemophilia and therefore should not be considered a long-term management strategy. This section goes on to provide the definitions of different approaches to prophylaxis, starting before or after any bleed or joint or other musculoskeletal damage. When started before any such damage, it is considered primary. It is, however, effective even in its tertiary form when initiated after significant musculoskeletal changes have set in. Depending on access to products and the concept of defining adequacy of replacement, at least three practice patterns have emerged. the higher and intermediate doses in the more resourced countries, and the lower dose approach in the less resourced countries to replace episodic treatment. It cannot be overemphasized that the overall goal of all prophylaxis should remain the same, keeping the person with hemophilia free of any bleeds in the most cost-effective way possible. Personalization of hemostasis management as best as possible is therefore very important, regardless of starting doses within the boundaries of the healthcare system. Given the availability of the current products for hemostasis, the bar for successful hemostasis management in hemophilia has certainly shifted several notches in recent years, from targeting troughs of 1% to a much higher 3 to 15% or even higher equivalents depending on the product being used. People with hemophilia should be able to and are indeed living their lives with much greater freedom for vocational and leisure activities than was ever possible in the past. An unfortunate reality of the use of clotting factor concentrate that this field has had to accept is the incidence of inhibitors or neutralizing antibodies to the particular factor as a consequence of exposure through replacement therapy. This tends to happen in about 20 to 30% of people with hemophilia A and 3 to 5% of people with hemophilia B, with more recent data showing that this could be even higher in hemophilia B. Monitoring during the first 50 to 75 exposures for the incidence of inhibitors is therefore very important, as almost all inhibitors develop within this period. Management of this most serious complication is emphasized from two aspects: the management of hemostasis with bypass agents, as in the past, and now much more effectively with the factor VIII mimetic emicizumab, and the concept of inhibitor eradication with immune tolerance induction, which involves repeated administration of high doses of clotting factor concentrates over several months, a very demanding and expensive mode of treatment. Appropriate management of musculoskeletal complications, which are often inevitable when hemostasis management is not early and adequate, make up the next principle described. A range of complications from synovitis to fractures and pseudotumor have been covered in this section, which also emphasizes the need for a team of musculoskeletal experts to manage these complications effectively. They include physiatrists, orthopods, physiotherapists, and occupational therapists as needed. As hemostasis moves into the modern era, this aspect of hemophilia care will hopefully see transformational changes in the future with marked reduction in these complications. With more effective hemostasis care, people with hemophilia are living longer and tend to have life expectancies similar to the general population. It is understandable that they will be subject to lifestyle diseases and age-related morbidities, particularly cardiovascular. The management of such issues make up the next section of the principles of care. It also considers the management of carriers, some of whom may have severe symptoms depending on the level of factor they have. This section provides broad principles of management of people with hemophilia from an early age to older age. Of course, one should recognize that wide variations would exist around the world depending on the healthcare system and societal expectation in this aspect of management. The final principle relates to the assessment of outcome, a relatively neglected aspect of hemophilia care in the literature till about 15 years ago. Two important components have been addressed: rate of bleeding in joints or other sites reflecting hemostatic efficacy, and the other related to musculoskeletal function. Recognizing and recording bleeding into joints can be particularly challenging as its clinical features vary a lot, making it rather difficult not only for patients or his family members to accurately report these events, but even for healthcare professionals to agree on such assessments, which should be quantified as annual or annualized bleeding rates. It was only in 2014 that the Factor VIII and IX subcommittee of the Scientific and Sensation Committee of the International Society for Thrombosis and Hemostasis attempted to provide a definition for joint bleeding to bring some standardization of its recognition as the pivotal event, which is not only the best surrogate marker so far of long-term outcome, but also the parameter on which new therapeutic products are registered. The second aspect of outcome is the overall musculoskeletal function, which is now considered within the broad framework of the WHO International Classification of Functioning as shown in this cartoon. A detailed discussion is out of the scope of this presentation, but what this emphasizes is that outcomes in conditions such as hemophilia are a function of the disease itself, other personal factors, and the environment in which the person exists, including the therapy received and other interventions as shown in the blue boxes. They need to be assessed under 3 domains as shown in the green boxes: body structure and function, which would essentially look at joints and muscles in this case, activities that the person is able to carry out on his own, and his participation in society in more complex interactions with the community, shown in green. Over the last 2 decades, several validated clinimetric tools have developed to help document these outcomes in a scientific manner, clinical and radiological assessment, activities, and participation. However, this can be very effort intensive and therefore remains a challenge to implement in practice. They are extremely important though, not only from the point of view of optimizing clinical management, but also for advocacy for better treatment, and should therefore receive their due attention. What I would like to conclude this presentation with is that the Principles of Care section of the treatment guideline provides an overview of the organization and delivery of care for people with hemophilia, along with the principles which should guide the goals of all intervention. There are detailed presentations on each of the sections of these guidelines, which will provide more specific context for those interventions. And now I have the pleasant task of acknowledging all the people who made this guideline document possible. On the left are some of the very well-known healthcare professionals in this field from around the world. And on the right are some of the very well-informed and engaged people with hemophilia or their caregivers, also representing different geographies. A whole lot of professional staff also worked in different aspects of the project, led by Donna Coffin from the WFH and the methods expert, Sandra Zellman-Lewis, along with many more, as you can see from this long list here, who have all contributed in very significant ways in making this the most evidence-informed, consensus-based guidelines for the management of hemophilia so far. And finally, I also want to acknowledge the support of the Hemophilia Alliance in developing this presentation. Thank you for your attention.